A very good afternoon to all of you and welcome to the GMOA Academic Cow program. So the today's topic is topical therapy for the skin. Are you aware? So we have invited Dr. Indira Kahawita, who is the consultant dermatologist attached to National Hospital Sri Lanka. She also was the past president of the Sri Lanka College of Dermatology and Aesthetic Medicine. And also she holds a membership of the Cosmetic Evaluation Committee of 𝗦𝗨𝗕𝗦𝗪𝗕. So without taking any time, let me invite Dr. Indira Kahawita for the lecture. Over to you, madam.
Thank you, Charuni and the team for inviting me to do this lecture. Actually, I requested that we wanted to discuss this topic because I'm seeing, as a dermatologist attached to the National Hospital of Sri Lanka, I'm seeing so many instances where doctors' knowledge regarding topical therapy for the skin needs to be improved. And also there are some disturbing things that we are noticing over the past 1 year, especially regarding things that we are applying on our skins, whether it be medication or whether it be cosmetic products. So because of that, we thought it's high time that we discussed these topics with the doctors so that they will take this. Firstly, they will improve their practices. Secondly, they will take their message to their patients. So, the first few slides, I will discuss with you the basics of topical therapy for the skin, because there are certain things that you need to consider when you are deciding on local applications, and then there are certain basic principles that you need to be aware of. So obviously, the first thing to consider when deciding on local applications is the diagnosis, because you need a diagnosis before you start applying. Now this especially is pertaining to skin diseases. But even in the case of using a cosmetic, you need to know why you are using this. You should not use cosmetics for the sake of applying, right? Then the second thing to consider is the condition of the skin, whether it is wet, dry or damaged, and the area to be treated or the body region to be treated. Obviously, the absorption of the local applications from the palm is not going to be similar to the absorption of local applications from the axilla, right? And then the risk of systemic absorption, which is actually related to the area to be treated mostly, and the possible adverse effects of what you are going to do. So it's very important that you know that there are the absorption of anything that is applied on the skin depends on several factors, out of which the most important thing is the skin region. So here in this chart, you see the relative levels of absorption of hydrocortisone applied at various sites. So you can see, if you take the forearm as 1 or the denominator, the forehead and the scrotum, the absorption is extremely high. The scrotum, it absorbs about 40 times of the whatever you apply compared to the forearm. And then look at the scalp and the axilla. It's almost 4 times the absorption that occurs in the forearm. So in the scalp, this is actually because of its high vascularity, and axilla because of the thin, more sensitive skin. So if we consider that the same that goes for the axilla goes for the submammary and the groin region. Remember, whatever you apply on the skin, the absorption is about 4 times that of the forearm in the flexural skin. So when you are going to decide on a local application for flexural lesions, please remember this, right? And then The other things are the formulation of the local application. As you all know, ointments are better absorbed than creams. And then the condition of the skin. If the skin is wet, it absorbs better. This is very important in the case of the use of moisturizers or emollients. So the best time to apply your moisturizers is to use it just after a bath. So you wash yourself, towel dry and immediately apply. With that, the absorption is better and also you save a lot on the amount of cream that you're going to use. Then obviously damaged or macerated skin absorbs more, therefore the risk of adverse effects is more. So in case of somebody who is having exfoliative dermatitis where the skin is damaged and where almost 90% of the skin is involved, even diluted corticosteroids applied on that kind of skin, the absorption is much more than what you would have on an intact skin. And obviously, there's less absorption with thickening of skin. So when there are thicker lesions, we need to use other measures to improve absorption. And then if there's occlusion, there is higher absorption when you use it under occlusion. So this occlusion may be intentional by way, like now say for instance, I usually advise my patients to wear socks when they apply foot creams when they have cracked heels, so that the absorption of the foot cream and if any other medications that you use will be much better if you use it under occlusion. But the other unintentional occlusion is, especially if you apply creams on your flexures and then when you wear your tight fitting undergarments, especially the submammary region and the groin fold. So again, the absorption of those even the mildest forms of steroids that you apply on those areas will be much higher when you wear your tight-fitting undergarments on top of that. And so remember all these things when you think of prescribing anything to be applied on those sensitive areas of skin. Then there are some other principles of topical therapy. Remember, it's always important to maintain the barrier function of the skin. And the restoration of barrier function can be done with mild soaps and emollients. And the basic rule in managing, especially managing eczemas is, if it is dry, wet it. If it is wet, dry it. Right? So this doesn't mean use of water. Right? Let's see. What are wet lesions? Wet lesions are like this. This kind of oozing lesions. So how do we dry it? You dry it by using astringents like Condis solution. The ideal concentration of Condis or potassium permanganate is 1 in 8,000 or 1 in 10,000. So the solution that you prepare to achieve this is like this. So remember, when you tell a patient to use Condis, you will advise them about a lot of things. You can just say Condis dala hodanna. That is not going to help. Because if the lesion is oozing like what you see on the screen, the easiest way you can do that is you have to tell them how to prepare the Condis solution. Otherwise, the patient will try to use a more concentrated Condis solution expecting better results. But if you overdo this, you can end up with Condis burns. Therefore, the best way you can do with this lesion is make it into a somewhat deep container and dip the foot in it. බේසමක් වගේ එකකට හදලා කකුල දාගෙන. If the oozing is really involving a lot of areas, especially an entire limb, we ask them to use Condis compressors, where we cover the area with a dry bandage and then ask the patient to wet this bandage with the Condis solution. But remember, Condis will have his astringent properties irrespective of how much water you have in your skin. So if you apply Condis to dry skin, it will dry the skin further. Therefore, when you prescribe Condis to somebody, you have to always tell them the moment the oozing stops, you have to stop using the Condis. Otherwise, what will happen is they will get into more trouble when the lesions dry up. So usually the average duration of application of Condis solution should be 3 to 5 days, 5 days maximum. Okay, so how do we manage dry lesions? Again, we are not going to manage dry lesions by applying water. Whenever we say you have dry skin, the first response the patient will have is, Doctor mang wathura bonawa. Or the other way around, the mother will say, Doctor me lamaya thiwenna wathura bonne naha. But actually, your water intake will not have much effect. Yes, you need a proper water intake, but you cannot change dry skin by drinking more water. Because the skin dryness actually depends on, yes, transepidermal water loss has a very mild effect on this, but it's mostly depends on the oils that you have on your skin, right? So the sebaceous gland secretions will have a much more effect than on the dryness of the skin than the water that will have the effect that water will have. So, to manage dry lesions, we use emollient creams and lotions, and like I have listed a few things that we use as emollients. The aqueous cream and emulsifying ointment are the two commonly used things in our practice in hospital settings, and these are prepared in-house. And these, I mean, thousands and thousands of patients have been managed with aqueous cream alone. So, aqueous cream is a good enough emollient for most of our patients. Then when we add urea, we actually improve skin hydration, and also addition of urea is good to treat thicker, more scaly lesions, more scaly skin. And then there are more high-end products like ceramide containing preparations, Syndet, vegetable-based preparations like oatmeal or sorbolene. So these are more modern, more like kind of patented kinds of molecules which are added to more high-end kind of moisturizers. But remember, all these high-end moisturizers fall under the category of cosmetics, not under the category of medicines. So only local applications which fall under the BP or British Pharmacopoeia will be considered as medicine. So far out of these emollient kind of creams, only things that will come under medicines are aqueous cream, emulsifying ointment and 10% urea. So all these other things will be considered as cosmetics. So if you are going to buy any of these, if you are going to prescribe any of these high-end moisturizers to your patients, be aware of the taxes that the patient will have to bear. Right? So when they go as cosmetics, obviously they will be taxed. So the price will be much higher than the price that the patient has to pay for a generic brand of aqueous cream. Then we use keratolytic like salicylic acid and colta, especially when we treat lesions like psoriatic lesions, we use salicylic acid and colta to reduce the thickness and the scaling of the lesions. And then we have two other things, creams, lotions and ointments. These are different formulations. So creams are water-based, so more sort of wet lesions, creams are based more better for wet kind of slightly wet lesions. Creams are thicker, they lubricate more and less spreadable. But when it comes to lotions, they are thinner and more spreadable. They are sort of, creams are more solid, lotions are like semi-solid or semi-liquid. So I personally prefer lotions because in the morning it's easier, quicker for me to apply a lotion than applying a cream. And the other thing is, creams have a bit of a occluding effect. So especially when we prescribe creams to young children who sweat a lot, they say, I don't want to use it because of the sweating. So in that case, and especially during the hot, humid weather, lotions are better suited than creams. So that is by way of, now, when it comes to the other thing that we use very commonly is the topical corticosteroids. I'm sad to say that the topical corticosteroids are the single most abused local application in Sri Lanka. So you need to know a few basic principles about potency, base of the vehicle and the mixtures, right? So this is the classification. There's a classification of 7 groups of corticosteroids, groups or classes. So class 1 corticosteroids are the most potent or the super potent of corticosteroids. I have only used the names of products that we use in Sri Lanka. This list is much longer and bigger. So we don't have molecules like 𝗦𝗨𝗕𝗦𝗪𝗏 in Sri Lanka. So for us, the top and the highly potent steroid, topical corticosteroid is clobetasol, propionate. Whether it is cream or ointment, it is there in class 1. So this is like, if you think about armamentarium, this is like your cannon, right? Kalathuakkuva. So think of your way of using way of using steroids like the way the weapons that you would use in a battle, right? So you don't use what I tell people is අපි මදුරුවෙක් මරන්න කඩුවෙන් ගහන්නේ නැහැ. So, but what is happening now is we are trying to kill mosquitoes using a sword. So people think you can achieve a one-shot effect by using clobetasol. I will tell you later what will happen then if you do that. Then number 2 comes betamethasone ointment and then mometasone ointment. So you see mometasone ointment is in class 2, just below clobetasol. I talk to you about mometasone later, and then betamethasone cream is below mometasone ointment. And then fluticasone ointment is quite, now the Cutimed brand is not available now, it comes as Sticovate now. I just told you a few brands because these are the only brands that are available in the country, right? And then we have fluocinolone. Fluocinolone again, what we have is 0.2%, which is fairly potent, right? And then the other few that you need to know are desovine, desonide. Desonide cream can be used as a slightly more potent steroid than hydrocortisone. So again, to summarize, our order is clobetasol, betamethasone, mometasone, fluticasone ointment, fluocinolone, desonide and hydrocortisone. So you should actually start from hydrocortisone and go up, not start from clobetasol and climb down, right? Ideally speaking, clobetasol should be reserved for the use of dermatologists because we see a lot of abuse of clobetasol happening. Right. So now our topic is local therapy for the skin. So we need to know the major categories of local applications. We have emollients or moisturizers. We discussed them to some extent. So we know that they are used to hydrate the skin, and emollients or moisturizers are suitable for the majority of people in the country. And a fair percentage of persons in the country do have dry skin. And the major underlying factor for eczema and even psoriasis is the dry skin. So the mainstay of therapy in our management of both psoriasis and eczema is emollients. So what happens is, especially when you are as general practitioners or in the primary care setting, when a doctor is managing psoriasis or eczema, they will always concentrate on the steroid. not the emollient. That is why their treatment fails in most instances. And the other thing is, like these moisturizers, now even the body lotions that people use fall into that category, right? So moisturizers, I mean, we cannot make a sort of a very big demarcation between these so-called body lotions and things that fall under purely cosmetic categories. But again, be a little wary about the cosmetic category moisturizers and body lotions that are used in this country, because sometimes I have seen even these very innocent looking moisturizers giving rise to stretch marks, right? So I'll come to that later. Then the addition of keratolytics, which reduces the thickness of the epidermis, are suitable for the thick or hyperkeratotic skin or hyperkeratotic lesions. So this can be achieved by the addition of urea or salicylic acid or both, and also coal tar in the case of conditions like psoriasis. And also the addition of salicylic acid to steroids. So there are combinations of steroid plus salicylic acid available in Sri Lanka, but you have to be very careful about using them because they will, like, there will be an additional effect of steroid, the thinning of skin with the steroid as well as the salicylic acid. So be very careful about using these things in thick skin, and you have to make sure to tell the patient to stop the treatment the moment they feel that there's thinning. The skin is, when the lesion comes down to the level of the normal skin, they have to stop using this. The two other categories are anti-infective agents. Then you get antifungals, antibiotics, antiseptics, antiviral agents, and permethrin or other antiscabitic agents. I will not go into a lot of detail regarding this, but please remember, if you start somebody on permethrin, you have to tell them all the details about how to use it. Then we get the anti-inflammatory agents. Mostly these are topical corticosteroids, but there are other anti-inflammatory agents like non-steroidal anti-inflammatory agents. The most commonly used ones are tacrolimus, pimecrolimus, and calcipotriol. So how do we decide on the most appropriate local application? So this is clinical, right? So again, consider the diagnosis, site, age, and other co-medications. And remember, when we take a history in patients, now I teach medical students, you need to take a drug history of oral medications, any local applications, and cosmetics. All three have to be taken now because the cosmetic use and abuse is so common, right? So the co-medications means all three. And remember, it's highly unlikely for a lesion to have anti-inflammatory, bacterial, and fungal etiology. So these triple combinations, which contain steroid, gentamicin, and miconazole, or something similar, actually there is no indication for us to use them because, I mean, in somebody's practice, the chances of having all three coming together may be 0.1%, right? But we see this is happening all the time. So somebody told me, one of my friends, a doctor told me, we use this because ගල්ලහුරක් ගැහුවොත් එකක් හරි වදිවි. හැබැයි මතක තියාගන්න ගල්ලහුර ගහනකොට ඔය ගල් ටික අඹ ගහට වදින්නත් පුළුවන්, එහා පැත්තේ තියෙන වීදුරුවට වදින්නත් පුළුවන්. So don't break glasses. Right? What you are doing most of the time is breaking glasses, not picking mangoes. Right? And actually regarding triple combinations, now in 2019, Sri Lanka College of Dermatologists, then we were called College of Dermatologists, so we initiated action to stop the registration of these triple combinations of steroid, antifungal and anti-infective agents. So the decision given by NMRA was to stop registration, re-registration. So they stopped new registrations of triple combinations. And you know that all medications have to come for re-registration every 3 to 5 years. And by now, there shouldn't be any triple or double combinations of potent steroids with antifungal or antibiotics in the market. But I'm sure you all see certain products which are being available. Sorry. And because a lot of doctors and even pharmacy guys and patients have been used to using these triple combinations, now what you do is you combine. Now the XXX GM is not available, so you use XXX, then XXX and metronidazole. I mean, fortunately, we don't have gentamicin creams, so you try to combine 2 or 3 things and make up that combination. Please don't do that. The most important thing is, the moment, for me, when somebody is using one of these triple combinations, what they are telling aloud is, look here, I don't know what the diagnosis is. So, I mean, do you all remember this, the story about the diagnosis of IDK and, IDK or GOK and the treatment with ADT? So it's either I don't know or God only knows, and you treat it with any D thing. Right? Okay? So please don't be a doctor who does that. Right? I mean, yes, even for me, there are times that I would have to say regarding the diagnosis, IDK, yes. Even today, there were patients in the clinic where I didn't know the exact diagnosis. In such instances, I have the benefit of going on for investigations. You have the benefit of referring the patient to a dermatologist, right? So why don't you do that and give the patient the benefit of getting a proper diagnosis and a management rather than trying ADT? Please don't do that, right? And okay, there may be a few patients where we are not sure what is happening, but it's not feasible or practical to send the patient to a dermatologist. Then, if you don't know whether it is infective or inflammatory, please treat the possible infection, right? For general purposes, what I would say is, a itchy rash in the flexures is fungal until proven otherwise. I'm not going to talk a lot about fungal infections, but please remember, tinea is one of the most difficult conditions to treat in Sri Lanka now. Now in our clinic at NHSL, 20% of our new patients have tinea. This was never ever seen in Sri Lanka. Our prevalence, I don't know about the population prevalence, but the clinic attendance, always infections were less than 10%. Now, tinea alone is 20%. It's happening because of this steroid abuse and the patients abusing antifungals. So, tinea has become a very big problem, and the amount of money the country is spending on oral antifungals is huge, right? And our patients have to be on very high potent oral antifungals for very long periods. So that because of that, for your purposes, any flexural rash, itchy flexural rash, is fungal in etiology until proven otherwise, and have to be treated with pure antifungals, only antifungal. Don't add even hydrocortisone, please. Okay, what happens is doctors do add, they prefer the addition of a steroid because it takes care of the inflammation and the itching and the scaling. So the patient feels better. The patient feels relief from the symptoms quickly if you add a steroid. So even dermatologists used to add this earlier. But the moment you add this, you are reducing the skin's defenses, so the local immunity goes down. And when the inflammation goes down and when the patient feels better, the patient will invariably stop the treatment. They will continue if they are scratching. Right? So if you cannot bear the scratching, give them some antihistamines. Right? And the other thing is, don't add anti-inflammatory agents if you are not sure of the diagnosis, because then what will happen is we will also not be able to diagnose, because you will be creating what we call an incognito lesion. And also avoid different combinations for the same rash. Say you give miconazole today, next week the patient comes and tells you I'm not getting better, then you give terbinafine, and for good measure you add a bit of antibiotics. Don't do this. Look at this, right? Now, when I was working in 𝗦𝗨𝗕𝗦𝗖𝗥𝗕𝗓𝗪, I did a study on my patients with tinea, and out of 76 patients for whom details of previous treatment were available, almost half of them, like about 1/3 of them, had used betamethasone for the tinea. And triple combinations used by another, like 20% of our patients had used triple combinations. Okay, and like these two pictures here, what you are seeing are not a collection of creams. These are two people's 𝗦𝗨𝗕𝗦𝗪, right? So the green one is somebody's 𝗦𝗨𝗕𝗦𝗪, the blue one is another person's 𝗦𝗨𝗕𝗦𝗪. So this is all done by, now look at the things you all have used, right? You use permethrin, terbinafine, miconazole, fluticasone, the triple combinations, everything for one patient. Now, when a dermatologist says this, the only inference we can take is this doctor doesn't know what they are doing. If you don't know, please refer the patient, right? I mean, there's nothing wrong in referring a patient. Okay? So what about topical antibiotics? I think a lot of us have this idea, no harm. It's okay, it's an antibiotic. No, it's okay to use. Please remember, these are not harmless. They may lead to resistance or sensitization, especially if you speak to one of the microbiologists. Once a leading microbiologist said dermatologists are contributing to drug resistance, especially antibiotic resistance, by using topical antibiotics for their skin lesions. I was in the audience. I felt really, embarrassed. But it is true. Because fusidic acid, if you think about oral fusidic acid, it's a reserved antibiotic. What they say is, according to microbiologists, even if you use it as a topical agent, that could trigger development of resistance. So you should not throw away fusidic acid. And mupirocin is the agent that is used for MRSA decolonization. So you cannot throw these away by just applying on every pustule and abscess that you see on anybody. And then, our doctors and patients are very fond of these betamethasone N combinations, right? Don't use this because neomycin can cause contact allergies, especially in case of venous eczemas. Never ever use. I don't think I have ever prescribed betamethasone N combinations, ever. Right? Then, what about these GM preparations or G preparations? Gentamicin is a gram-negative. Its action is gram-negative. So, skin and soft tissue infections are due to gram-positive. So, what is the action? There's no action, right? You just, ඇත්තටම අපි අපිව රවට්ට ගන්නවා ඇන්ටිබයොටික් එකක් ඇඩ් කරනවා කියලා, right? And then the use of clindamycin or erythromycin for acne. I see a lot of patients managed by GPs coming and saying, I used clindamycin cream for my acne. Clindamycin will only have an antibacterial action, but acne pathogenesis has so many other things. So you are not managing those. So monotherapy of antibiotics is topical antibiotic monotherapy is not recommended for the management of acne as well. So the bottom line is topical antiseptic are a better choice for possible skin infections, and if there's actually overwhelming infection, you can go for oral antibiotics rather than going for topical antibiotics. But again, don't forget antiseptics can, especially iodine containing antiseptics, can cause contact allergy. So that is all for topical antibiotics. What about topical antifungals? I will just tell you a few facts about topical antifungals. Before that, I'll tell you a few things about tinea. Tinea is due to filamentous fungi or dermatophytes, and about 30 years ago, the organism causing dermatophyte infections in Sri Lanka was called Trichophyton rubrum. That was quite sensitive to most of the treatments that we used, and metronidazole cream alone was enough. When I started as a dermatologist doing private practice in 2008, whether it was the hospital or the private sector, what I gave them was bisulfalvin for 1 month and metronidazole cream twice daily for 1 month. That was good enough. But now if I give that, the patient will come back a week later saying, Doctor, kisima deyak une naha. So why is that? The organism has changed. When we conducted, the college conducted the island-wide survey study, and we found that about 60% of our patients with tinea were harboring the organism called Trichophyton 𝗦𝗕𝗏𝗕𝗦𝗖𝗥𝗜𝗕𝗘, which is mostly a zoonotic one or an animal fungus. So this has a different sensitivity pattern to Trichophyton rubrum, and that is less responsive to most of the conventional antifungals. And now, after 2020, the world has diagnosed another organism called Trichophyton 𝗦𝗕𝗓𝗕𝗓𝗕𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓𝗓 furious about this, but Indian tinea. Right? This organism we cannot prove by culture, and we have to do genetic studies, because if you do culture, it will come as mentogrophitis. This Indotinea guy, 70% of the organism is resistant to oral terbinafine, let alone griseofulvine, right? And we only evidence that we have regarding Indotinea in Sri Lanka is, now when we did this study, we had samples, preserved samples, and we have sent a random collection of 10 samples to Germany for confirmation, and 5 out of them have harbored this new organism Indotinea. So I'm not telling that 50% of our organism is Indotinea, but we do have Indotinea infection, which is known to have multiple antifungal resistance. So that is what we are facing now. And this is something I never expected to see in my lifetime. Right? So this is happening because as doctors, as patients, as other healthcare workers, we are failing in our duty. As doctors, we don't go for a proper diagnosis and we try to use the 𝗙𝗓𝗪𝗓. As patients, they don't listen to us, and they will try to stop the treatment either halfway through, or they will, without any proper diagnosis, they will use all these kind of friends treatments. And the other thing is they will go to a pharmacy and buy something. And the third thing is pharmacists. They will give, now what's happening is, earlier when somebody says, I have a rash, they used to give an antifungal. But now they have these triple combinations, so they will give this. And then what happens is, patients find it easier to go to a pharmacy and buy something and apply, and they get better also because the itching is less. So with all these things coming together, now we are facing a very difficult situation in treating tinea. So, okay, so if you diagnose somebody with tinea, what I would do is, I will usually give 2 antifungal agents, different, and one for the morning, one for the night. Please don't mix these two. And then apply on the lesions and about 2 centimeters outside the lesion. So it has to be applied outside as well, not only on the apparent edge. Twice daily regular applications, you can't, do once daily applications, and need to continue for a month after apparent clearance of lesions. So I usually, when I write a prescription, I would write, put a 𝗙𝗦𝗕𝗦𝗪 and say 3 months, masa 3. Sinhala liyane masa 3. So the patient can't say, I didn't know. And please avoid combinations of steroid and antifungal agents to treat tinea. So I discussed this about the temporary relief, right? So what about other antifungals like NOAs? I'm mostly talking about azoles. The things that are available to us are, I haven't put a list here. The antifungals that are available to us are the azole group, miconazole, clotrimazole, ketoconazole, and there are like not very common ones like isoconazole and econazole. And then we have terbinafine, we have cyclopirox, we have amorolfine. So those are the products that we can use, and the good old wheat field ointment can still be used. It still works. So if you use steroids, this is what happens. Now can you all see this scaling here? Aren't we seeing?
We can see.
Yeah. And can you all see the scaling here on the face? And like it is just redness and scaling. You can't see an active edge. And then again here, can you see the stretch marks and the edge of active edge of tinea, right? So there you can see this was due to a combination of clobetasol plus gentamicin plus miconazole. So the miconazole has not acted. That is why you have the active edge still. But the clobetasol has acted and given rise to the striae, and this was a young woman. So what if this happens to your daughter? Would you be happy to have your daughter end up like this? No. Right? So please don't do this. Yeah. Coming back to topical corticosteroids, this is where I want to go to town about. Topical corticosteroids should be used with extreme caution. Now, one funny thing I had noticed is some doctors are giving hydrocortisone and betamethasone and asking the patient to mix the two and use. I don't see the rationale behind this. So please, let us learn about these. I showed you the classes of corticosteroids, and we are fortunate to have at least 1 brand each from each category. So I am trying to give you a bit of a guide as to how you can use these corticosteroids. Okay? So before prescribing a corticosteroid, ask the question, am I sure of the diagnosis? Is this an inflammatory condition where I can use corticosteroids? Is there a risk of infection, either bacterial or fungal? And the age of the patient, the site, and the amount used, and the cream, whether it is a cream or ointment, right? I'll tell you about the amount. Usually there is something called the fingertip unit. A fingertip unit means, now if you all can, now unfortunately I forgot to put in a picture here. A fingertip unit, think about the toothpaste ads. In a toothpaste ad, you see a brush and the toothpaste right across the bristles. So think about your index finger, the last phalanx, the last phalanx, the tip of the index finger, and think of the toothpaste picture. So what you get by just putting one line of squeezing one line over the last phalanx, the fingertip, what you get there is equivalent to 0.5 grams. That can be applied to an area which can be covered by both your palms. Right? So that is, if you are applying it on a child, it has to be, now you take it onto the mother's hands and it has to be the mother's palms. Okay? You can't take it into the mother's fingertip and apply on the area covered by the baby's palms. Okay? So if you go by that, you can use the contents of a 15-gram tube for 30 applications. Right? So that is the amount you can, this is something you can tell the patient. And then what you do is you take the fingertip unit and you decide on the area to be applied, and then you put like this blobs and then spread it out. That is how you have to apply. And one question our patients ask is, Doctor, ඇඳුම් වල ගෑවෙනවා නේ, රාට නිදා ගන්නකොට ගෑවාම bed sheet වල ගෑවෙනවා. I actually can't fathom why do you want to apply like that? You apply the amount that can be absorbed. You don't have to apply a thick layer of any of these things. Right? Okay. A very rough guide. So, for a general doctor's point of view, 1% hydrocortisone should be used for all body sites in infants and in adults, face and flexures. Don't go beyond hydrocortisone for the flexures in anybody. And then desonide can be used for young children more than 1 year or so, or even an older infant, and the face in adults if they are not responding to hydrocortisone. Then fluticasone can be used for older children and also for sensitive sites in adults. Fluocinolone, what we have is 0.25%, which is quite potent, so don't think that fluocinolone is a mild steroid. It can again be used in older children and trunk and limbs in adults. Then mometasone, betamethasone can be used in the limbs in adults. Please, for your purposes, mometasone is not something to be used in children, not something to be used in babies, not something to be used in children, and not something to be used on the face of anybody. Anybody. Right? But the pathetic thing is, mometasone is being used on the face even by the beauticians, not you. I think out of these three, mometasone, betamethasone and clobetasol, I think betamethasone is the least abused. Right? And clobetasol. For your purposes, it's only for the palms and soles in anybody. Nowhere else, right? And resistant lesions in the limbs in adults, not for children. Yes, there are instances where a dermatologist will use clobetasol in a child. I mean, please reserve those for us, right? And remember, creams should be used for wet lesions and ointments for dry or hyperkeratotic lesions. Now, if you can remember this picture, you can do a fairly reasonable, good practice. Okay. Remember, mometasone is not a mild corticosteroid. Unfortunately, like I was a registrar when mometasone and fluticasone molecules were introduced to Sri Lanka. The cliche was the efficacy of betamethasone and the side effect profile of hydrocortisone. I have done this. As a registrar, as a senior registrar, I have done this. I used to give mometasone for vitiligo lesions in the face. Yes, it works, right? But with long-term usage, with post-market surveillance, they found out that there are a lot of adverse effects. Mometasone probably thins out the skin more than betamethasone. Definitely. If you think back, now we have combinations of mometasone and salicylic acid and a combination of betamethasone and salicylic acid. My experience in the usage of these two products in psoriasis is mometasone plus salicylic acid works better in psoriasis than the betamethasone plus salicylic acid. Why? Because mometasone is also causing skin thinning. So the plaques get thinned out quickly than the betamethasone plus salicylic acid. That is the potency of mometasone in causing skin thinning. Right? So please, please don't do this, because the thinning on the skin which occurs with steroids is permanent and you have to live with that for the rest of your life. I will show you a few pictures. And you know, we had, unfortunately, we used to have some quite cheap mometasone products, creams. And people got to know that it causes skin lightening, and like straight away, so-and-so cream, mometasone creams, the cheaper ones, people just used to apply this and say, Mama, make a gava sudu. So I'm telling you one brand, again, please forgive me for telling this brand, but I'm telling you this brand because it's not available now. I have met several persons who have said, Mama, Bitrio cream make a gava sudu. Right? Bitrio is no longer available, that's why I'm telling you the brand. Okay? So that is the situation of things in Sri Lanka. Right? But for your purposes, again, please, no mometasone for the face. This is what happens. You end up with a red face. Now, the two images on the right are dermoscopic images. You all can see the enlarged image where, now, the middle image, now, clinically you get these red patches. This is called, what we call 𝗦𝗨𝗕𝗦𝗕𝗦𝗕𝗓. You don't see the telangiectasia separately, but it's like a matted kind of thing. And then you see the redness, the entire skin is red. When we do dermoscopy, we see a brown skin. This is red, and you can very clearly see the telangiectasia. This, this is the effect of using 𝗦𝗨𝗕𝗦𝗖𝗥𝗕𝗦𝗕 for 3 months. Okay? Again, can you see the whitening? Can you all see the whitening of the skin, right? So these kinds of, and also the acne scars and then the redness, these are due to telangiectasia, right? But unfortunately, mometasone containing triple combinations are being used for, like again, one misnomer is, like a lot of people talk about pigmentation. Even our patients come and tell me, Doctor, mata pigmentation the තියෙන්නේ. Pigmentation is not a diagnosis. Pigmentation is increased pigmentation. Pigment, color, right? So people think, yes, pigmentation can be treated by anybody by using this. Now you see this TikTok. Pigmentation එකපාරින් එවත් කරගමු හරියටම. So I'm showing you these brands here because these are not registered. These are illegal, and if you as a doctor prescribe these things, and if something happens to your patient, you will be held responsible. Because you can't prescribe. I mean, these are prescription-only medicines, which are not registered. Okay? And you see that TikTok is saying, yes, අපි pigmentation අයින් කරගමු මේ නිල් පාට කොටුව ඇතුලේ තියෙන WhatsApp number එක. And then you see this hydroquinone, tretinoin, all these contain hydroquinone, tretinoin and mometasone. The current recommendation is, yes, you can use this combination for melasma for a month, not more than that. We have one brand registered in Sri Lanka. I'm not going to tell you the brand, you all know. But all these other brands, the Skin Light, Skin Shine, 𝗦𝗨𝗕𝗦𝗧𝗓, all these are not registered. And you see, look at the irony of that. You have, now Zydus is a company which is represented in Sri Lanka by a local agent. Ajanta Pharma is represented in Sri Lanka by a local agent, right? So these are not brought in by these local agents. And NMRA has not registered any of this. And you look at this. This is the other side of the skin light. This is the red box warning. And side by side, you see Fancy Paradise 𝗦𝗨𝗕𝗦𝗪𝗧. Yes. And the place was raided. I mean, I sent this same picture to NMRA and got them to raid. And the answer was, Mama danne naha. Mama danne naha meka betak. So this Fancy Paradise fellow does not know how to read English. Right? Now the box warning says, Schedule H, prescription only drug, caution to be used by retail only on the prescription of a registered medical practitioner. The red box warning says so. And the owner says, I didn't know that this is a medication. This is the situation of things in Sri Lanka at the moment. So again, please, doctors, please do not use mometasone in your patients for the face. There are indications for you to use, but not for the face. Okay. Is it only topical effects? Can they lead to systemic effects? Topical corticosteroids can be absorbed through the skin, and I told you how it can be increased. And now, do you know that now the trend is not fairness, it's whiteness, and it's not only your face, it's for the rest of the body as well. So people use whitening creams for the entire body, right? And especially, even without whitening, say if you use topical corticosteroids for the entire body in somebody with erythroderma or exfoliative dermatitis, the absorption will be much higher, right? And then it may act in the same manner as systemic corticosteroids. So the risk of diabetes, risk of hypothalamic pituitary adrenal axis suppression and other systemic effects are also similar. Now, my endocrine colleagues are saying that they are detecting increasing numbers of persons with unexplained adrenal suppression. So these are my personal experiences, 2 patients within this year. One with a combination of clobetasol and like a combination cream used for tinea. The other one is like she wanted whitening, right? Snow White whitening. So these are the cases. This is topical clobetasol. This was a kind of a penta combination. A 21-year-old male, extensive tinea. He has used this cream. He brought us about 5 tubes, right, Gani? And then he said, "Me wage 20ක විතර මල්ලක් ගෙදර තියෙනවා. අවුරුදු 2ක් විතර මේක ගෑවා." And he's again and again he is telling, "I get better only if I use this." So he has been using this, and he came to the OPD with purple striae, and the OPD referred him to the endocrinologist, and there was low random cortisol, and we are waiting for the 9-name cortisol and ACTH, and they have already started hydrocortisone supplementation for this patient. 21 years. And he was referred to me for the treatment of tinea, which is still flourishing because of the clobetasol that he has used. Okay, so now the healthcare system has to take care of him like for the rest of his life. Okay. The second one is a woman in her 40s. These were the cutaneous signs. I didn't feel like taking a photograph. Like, she looks so pathetic. I didn't want to, ask her for photography. Transparent, abnormally white skin, epidermal thinning, telangiectasia. I mean, you could see the blood vessel network. Recently, there was one person who has applied this clobetasol and gentamicin and miconazole combination. The skin was so thin, it looked like cling film. I could sort of do this. The skin could be අර skin එක උඩ මෙහෙම වෙනම උස්සලා ඔලියට ගන්න පුළුවන්. ඒ තරම් thin out වෙලා submammary region, right? So in this lady also it was like that. You could see the superficial blood vessel network. There was dry in unusual sites. Face was red. Multiple ecchymosis and poor wound healing. Even surgical scars were like really bad. Still, she was adamant that she wanted to have this cream. Okay, so now all our patients, now we have come to a stage where all the patients who come with striae, that we need to go for cortisol levels. That is where we stand now. And please, the main reason why I wanted to do this talk was this cream. Look at this. Dermi-5, clobetasol, gentamicin, iodochlorohydroxyquinoline is an antiseptic, and tolnaftate and clotrimazole are antifungals. Now, do you think this product can be registered in this country? If triple combinations cannot be registered, penta combinations definitely cannot be registered. So this is not a registered product. So therefore, even if we complain to the NMRA, they will raid, but they cannot stop. They will raid one place, but they cannot raid the entire country. Earlier, this used to be available for the past probably 2 years, because this is the culprit in that young guy with striae. 20 tubes of this over 2 years. So this has been in the local market, smuggled in for more than 2 years. And unfortunately, this boy says a doctor prescribed him this. So the main reason why I wanted to talk to doctors in Sri Lanka is to ask them, please don't do this. If you prescribe this, if you put your seal, and if somebody goes into adrenal suppression, you will be responsible. And you can't say, I don't know. Right? But this is illegal. You cannot prescribe something which is not registered in the country. So please, because, I mean, even though we know, I know that it is available even in Mathur. All over the country it's available. So at least if as doctors you can, not prescribe this. Because, I mean, not for anything else, just to save your skins. Please don't do this. Saving skin කිව්වහම මේ skin එක නෙමෙයි තමන්ව බේරගන්න. මේක නම් prescribe කරන්න එපා. කරලා අහුවෙන්න එපා මොනවා හරි වුණොත් you cannot safeguard yourselves. Okay? So, action can be taken when prescription-only medicines are being sold against regulations. So, all these can be raided according to whatever regulations that we have. These can be raided, right? And raids have been done, and like huge stocks of these triple combinations have been raided, but you cannot stop this. Okay, so that is where we stand now. Regarding regulation, regarding misuse, regarding abuse. Okay. Coming to cosmetics, this is just a list of cosmetics. So we can't say I don't use cosmetics, because your shaving foam, your soap, your shampoo, everything is a cosmetic. But these are not cosmetics. Okay? So what is the current status regarding cosmetic regulation? We need to know this. Cosmetics were regulated initially in 1980, the Cosmetics, Devices and Drugs Act. So C was before drugs, right? Then cosmetics were under strict regulation, but this was changed when the NMRA Act number 5 came into effect in 2015. So cosmetics were not regulated. Even now, this NMRA cannot take any action against, they cannot go for legal action against misuse or any illegal thing happening regarding cosmetics. So this is where we stand. So cosmetic regulation, a lot of us have been fighting for this, but so far we don't see a quick solution for this. So in a country where the cosmetics are not regulated, you need to know something about what's happening regarding cosmetics in the country. Why is it important to regulate cosmetics? Because we need to ensure the quality and safety of the products used by consumers. Right? Now, ideally, when they are importing, you cannot import without registration with NMRA if regulations are in place. Therefore, we can limit the number of products. But it's not happening now, so people can bring in cosmetics. And now when they are bringing in cosmetics, what's happening is now they are registered products, they are looking for a few things before releasing. But things are not in a sort of any satisfactory manner, things are not happening in a satisfactory manner. And when you produce things locally, you have to comply to minimum standards like good manufacturing practices. That means you can't produce creams in your salon or in your kitchen. But that's what's happening. I mean, cream manufacturing can't be a cottage industry. But it's happening, right? And then adulteration of products with harmful chemicals can be controlled if there is regulation, right? And if there's post-market surveillance, so much the better, right? And also about misleading advertising. I mean, I have stopped listening to radio, watching TVs, mostly because of these advertisements. And I get so angry, I have stopped listening to radio even. And remember, in case of cosmetics, only the safety is assessed, not the efficacy. Now, these are things which have come, which have been published. So you see the creams, okay? Yeah. Fresh and clear is one, fresh and white is one, right? Ujuba, even recently I saw somebody, one of our patients has applied Ujuba and came with some symptoms. I will be showing that to you later. And look at the list and look at the numbers. There was one containing 68,000. Now the mercury, allowed mercury amount is 1 part per million. And the WHO is actually pressing for no mercury. And look at these numbers. These are all in 5 figures. මිනිසුන්ගේ පඩි වගේ මේ ඉලක්ක. හරි? And look at these Zuni beautiful beauty cream, 60,680 at number 1. And then Kashi organic beauty cream at 64,000. Okay? So these are the amounts. And the recommended the thing is given there, mercury is 1 milligram per kg or 1 part per million. Okay, this is where we stand regarding mercury. Because mercury is one thing that we can check for. Okay, and mercury is the commonest. You see, there were some with amounts of lead, but mercury is the commonest. This is the evidence for steroids, the patchy whitening, acne, right? So if you see this picture, the patchy whitening and acne, the first question I would ask is, මොකද්ද ගාපු cream එක? Right? And the striae, this is a mild one compared to what we are seeing now. And then the severe acne, and there you can see the acne and the tinea, the edges of the tinea, right? Now these two have used just moisturizers, just moisturizers. They were not trying to become white, moisturizers, right? I cannot tell you the brands, but these were just moisturizers. This girl is one of the most pathetic. Now this is somebody for whom we should be looking for adrenal suppression. This girl is, now I'm telling you the story because for you to understand what's happening in the country, 15 years. And when she started developing these now she has been applying this so-called carrot cream for 3 years. So at the age of 12. This is an age where the parents would be buying the cream for her, not she going and buying it, right? And when she started getting this trial, the doctors had told them, mahat wena hinda. Now again, please remember, when children in this age, when they get physiological strife, there are certain areas where you would get it. You don't get it along limbs. And we don't even know whether she gained weight because of the steroids that she was taking. And the other thing is this pigmentation over the knuckles. The abnormal whiteness and the pigmentation, like this sort of contrasting pigmentation. This is the other thing you have to look for. And the most unfortunate thing is, I talked at length to the father. Still, I told them to get the blood sugar done and come back the next week. They never came. Right? That is where we stand. We find it very difficult to investigate these patients. My senior registrar now keeps them with her and does the biopsy immediately. Otherwise, they will vanish. Okay, just a few cases and I will finish. Now you see the ujuba. Okay? These are her feet. Daligala wagene. So look at this. And the amount of acne and scarring that her face has suffered. So these are permanent. These acne scars are permanent, right? Another pathetic thing, French white. French white has been, now I'm telling you this because mercury levels have been checked, right? Mercury content ranging from 1055 ppm to 10,000 ppm. And this woman has used this mercury containing product even during pregnancy. And in spite of my describing this to the husband as well, they never came to the clinic. I wanted to arrange for mercury levels. Right? Okay. These are her lesions. Nothing much, but these are actually dermal lesions. So she thought it was aluhang, but this is not aluhang. Now all these are cases that we have seen over the past month or two. Fresh and white acne. And look at the fine. Na? This is around the same cost for one tub. Tub එක ගන්න වගේ තමයි මේ ෆයින් එක. ෆයින් එක ගෙවලා ගෙදර ගිහිල්ලා එක ටබ් එකක් විකුණුවාම අර ගාන කවර් වෙනවා. And look at the severe acne. Now this is her cream. This is something I had never heard of, luxury royal pink. There was a dermatitis and look at the patchy hypopigmentation and depigmentation. Okay. Again fresh and white. This is NSBM salon. Right? They are the salon people prepare the cream. Right? These are the lesions. These are the lesions. These patients never come for a follow-up. All these things that we are seeing, we have reasons to suspect that there may be systemic absorption of mercury causing this sort of effects. Again, these are, now here again you see the pigmentation and the increased blood vessels. In this patient we biopsied and we saw the number of melanocytes was increased. That means there is something happening inside. So this is what's happening with these cosmetics. So I'm going to stop it here. leaving you to think about these things. What's happening in the country? What sort of advertising is happening? What sort of things we are facing with these cosmetics? Okay, so yeah, I think this is the end of this. So regarding cosmetics, what I wanted to tell you is, look at the comments and the shares, right? 257 shares, 7 දවස් 7න් සුදු කරනවා. So there's a lot to be done, but in the meantime, be very wary about what cosmetics you use. My principle is, I will not advise my patients to use any cosmetic that I don't use on myself. So I usually use things I prescribe, and I tell my patients to use any of those things, nothing else, because we cannot be sure about the cosmetics. So that is where we stand regarding cosmetic products. And yes, so that's all I wanted to tell you. So the take-home message is, yes, topical therapy, do it with an understanding. If you do that, you are very highly unlikely to run into trouble. Thank you so much, and sorry for taking so much of time.
Thank you very much, madam, for that very eye-opening lecture, I would say. And there are several questions we have received. First question is how to treat early callosity formation. Can't it be treated without any surgical interventions?
Actually, regarding callosities, we don't go for surgical interventions now. What we usually do is, there are lotions containing salicylic acid and lactic acid. There are several brands available. You can apply those. And in our clinics, we treat those with cryotherapy. Right? Now, we rarely go for surgical options.
Yes. The second question is, madam, why you don't take legal actions for these kind of advertisements?
Legal actions cannot be taken because there is no act. Right?
Exactly.
Simply said. Actually, if somebody wants to take legal action, what can be done at the moment with the available provisions is, if anybody, the consumer can complain to the Consumer Affairs Authority. The CAA Act is strong enough, and the CAA is actually motivated to do this. But the unfortunate thing is, our consumers are not motivated to do that. They expect the doctor to do that. Actually, regarding that skin light cream, I told the patient who came with some symptoms due to that cream, she had some depigmented patches, and I told her to just write a letter to the CAA. She said no. Let alone that, with that Dermi 5 cream, I have asked so many patients, where did you buy this? Kotahene pharmacy kin gatta. Maradane pharmacy kin gatta. Never ever will they tell us the name. That is where we stand. So, I mean, how can we take legal action? Now, what I actually tell, even the media, what I actually tell them is, yes, if we want to put a stop to this, it's the consumer who has to do something. If the consumer stops buying whitening creams, the market should not be like this. Then at the moment, if somebody wants to stop it, it's the consumer, not the doctors.
The next question is, what kind of corticosteroid should be given for atrophic vaginitis?
I don't think it is something that can be answered like this, because I didn't want to go for that kind of specific situation. I just wanted to give you a guide as to what to do. And anything beyond that, I think we need to take a sort of a clinical decision. I don't think we should be giving that kind of advice on a forum like this.
There are so many combinated brands with antifungals and topical steroids for which kind of lesions we can use these preparations?
Actually, now according to what's going to happen and what's happening now is the only combinations that are going to be allowed with antifungals is 1% hydrocortisone. So the hydrocortisone plus antifungal combinations, there are only 1 or 2 brands. All these other things, including this clotrimazole and beclomethasone combination, which is a household name, all these will be out of the market because those are too potent. The combination of hydrocortisone and clotrimazole or hydrocortisone and miconazole can be used for conditions like seborrheic dermatitis, where there is a fungal etiology as well as a inflammatory skin condition. Other than that, usually we don't need these combinations.
What is the suitable for hyperpigmentation on facial lesions?
Again, I told you, pigmentation is just a term. You need a diagnosis, right? You need a diagnosis, and there are several conditions which can give rise to hyperpigmentation of the skin. So, depending on the diagnosis, the treatment will vary depending on the diagnosis, depending on the patient's age, whether they are males or females. But one thing I can tell you, any facial hyperpigmentation, the most important thing is sun protection, right? So advise your patients on that.
How to treat melasma during repeated appearance of pigmentations after stopping 1 month of treatment?
Yeah, melasma, if you think about the pathogenesis, melasma is due to hormonal changes. So age, heredity and sun exposure. These are the 3 main reasons. So you cannot change aging or your gene structure, right? So because of that, melasma cannot be, cured. Melasma, you need to go for maintenance therapy with less potent lightening agents like, not things like hydroquinone or tretinoin. They have to be used for a short period, but things like silymarin, things like arbutin, right? Niacinamide, those things can be used for a longer period, but their depigmenting action is very mild, but they can be used as maintenance therapy. Anyway, you need maintenance therapy for melasma. Otherwise, it recurs. If you stop, it recurs.
What can be given for seborrheic dermatitis?
I answered that. Anyway, seborrheic dermatitis needs controlling of dandruff. So, an anti-dandruff shampoo is mandatory.
There's one suggestion also. Why can't we start to put a seal or a logo of pharmacy when patient taking medications?
What?
Then we can pick those illegal products.
I didn't get it.
Why can't we start to put a seal or a logo of a pharmacy? So we can pick those illegal products.
Do you think the illegal products are given on
Also in
prescription?
Yeah, that's the thing.
Illegal products are not given on prescription. The pharmacy keeps them, and actually what's happening is the patient goes to a pharmacy and says, "Kasana rash ekata cream ekak den." And you know this thing about Dermi5. Now some pharmacies are telling, make a Honda Indian product ekak, make a leda pahakata beth tiyenawa. Api gawa vitarai tiyen. That is the marketing the pharmacy does. And they will not put a seal and give them. And I don't think anybody will write a prescription for Dermi5. Right? But if you have ever written a prescription, please don't do it hereafter.
So one of our colleagues also has sent a case study So this is the case. A 26-year-old lady diagnosed with acanthosis nigricans and treated with following by a consultant dermatologist and mometasone and salicylic acid ointment for face and beprasone cream with urea cream for underarms, behind the neck and sub-mammary area. Now she is using above creams for months. She came to my PP. Skin darkness, pigmentation has improved well, but recently she has developed pityriasis versicolor around the areas that the above were applied. So what can I do for her in the further management? That is the question.
Well, I must say, that's not a easy thing to answer. And firstly, I would not like to criticize this management because it's not ethical to do this, right? But there are things that can be improved. First, I would say I will first treat the versicolor, and then if they have been using these steroids for a long period. Actually, this is something I couldn't tell you, like especially if you use steroids for a long period, especially in the lower face, the area becomes addicted. Then you end up with what's called perioral dermatitis. So what I have done and what I have found to be effective is you step down. Every 2 weeks, you bring down the potency of the steroid. So if you start with mometasone, I bring it down to fluocinolone and then fluticasone if it is available, then desonide and then hydrocortisone. Every 2 weeks, I bring it down. That helps. Otherwise, the moment you stop the mometasone, it can, I think, again, this is not to criticize, but this mometasone stuff, the fear of mometasone, I told you, when we were registrars, we were told that mometasone is like hydrocortisone in side effect profile. So because of that, there may be a few dermatologists who are not aware of these new things and who may be still using mometasone. Right? I know that it's happening. It all depends on how you update yourself. Right? So this can happen. Again, I don't want to criticize anybody's practice, but if you want to do something about it, that's how you would do. You reduce one by one and treat the versicolor
First.
Yeah.
Finally, there's another question. Madam, can you tell us some more illegal products using in Sri Lanka now?
No, I don't think. Illegal products in the sense, my first message to you was not to use this Dermi5 thing. Again, I'm telling you the name because patients are telling me that doctors prescribed it for them. So I don't want any MBBS doctor or any consultant prescribing this. But other than that, there are so many products which are not registered in the country. Now, do you know that we had a shortage of methotrexate in the past few months? We only have one brand of methotrexate registered in the country. And that went out of the market in January. And then there were certain pharmacies who were selling another brand of methotrexate at a higher price. And they are like, they had to, if they could buy the entire month's supply of methotrexate at 500 rupees, their one tablet was about 500 rupees. Okay? But, we just prescribe by name methotrexate. And I'm sure patients must have bought the other brands. Right? So, the legality of that is not known to me. Okay? So, that is what's happening in the country. So, the number of illegal products, I must say, I don't know. There are illegal or fake products for medicines. There are fake products for most of these cosmetics. And actually, another thing now that's happening is most of these funny cosmetic products which are registered. The sole agents are now lodging complaints with the CAA saying that there are fake products of their brand. Now, if we find any side effects due to one of these products, and if we say this product is causing this, all that the local agent has to say is, I have already complained that there are fakes. Right? So there is no relief for the consumer. There's nothing I can do about it. There's nothing a doctor can do about it. There's nothing the NMRA can do about it. And they have already made their complaint. Right? So these illegal products, it's very difficult. So as a general rule, what I would tell you is, okay, see whether the things have any local or international standards, SLS or ISO. Are these sort of reputed brands elsewhere? Are these registered under NMRA? And the other thing is, if you are buying something, sort of a high-end brand, compare the prices outside and the price that you pay for that here. Right? Because given the taxes that Sri Lanka is, having for cosmetics, you cannot buy any high-end products at a lower price than the international market. It has to be higher unless you buy it at a duty-free shop. Right? Now the lipsticks that we buy for about 10,000 rupees in a duty-free shop were available in certain shops in Sri Lanka for 2,000. Yeah, those are counterfeits. Right? So that's how things are happening. So a lot of things are happening. So the general rule, those are the things we can, use to find a reliable product.
So the questions are coming up. Please explain the use of permethrin.
Oh, yeah, I think that is something you need to know. Okay, if you are using permethrin, and remember, there's something like an outbreak of scabies. I'm seeing it not only in, these highly overcrowded areas, even certain fairly well-to-do people are having scabies, right? I recently had a foreign boy from one of the international schools coming with scabies. He came to the hospital clinic. Permethrin, if you are using, it can be used for children over 2 months of age. It's safe in pregnancy. Application is, it comes as a 30-gram tube, and one tube has to be applied to them in its entirety, like completely, for an adult. And you have to apply it from neck downwards, apply to the entire body, neck downwards, and leave it on for 12 hours, and then wash it off. So the permethrin has to be applied to the genitalia, it has to be applied under the nails. So what I would tell them is, kala bila gan. Nala gan නෙමෙයි kala gan. හරි? ආයි අත හොදන්නේ නැහැ. ඕවා අපි කියන්න ඕනේ මොකද අපි usually cream ගාලා අත හොදනවානේ. Then you repeat it in 7 days. That is to kill the second generation that come out of the eggs. And then the treatment of fomites. රිදිතම්බන එක ඒ ඔක්කොම ටික වෙන්න ඕනේ. Entire family has to be treated. So 30-gram tube to the entire body for an adult. For children, it has to be a smaller amount. 12 hours application. Repeat 1 week later. Entire family to be treated. And like heat treatment too. Yeah, if it is a baby, the head and neck also has to be treated. And the heat treatment for their personal belongings, personal clothing.
One more question.
Yeah.
Can you explain starting antifungal in pediatric age?
Oral.
And not specified.
Yeah, I mean, most of the topical antifungals can be used in children. I think for LRH, the preferred antifungal is ketoconazole, topically, not orally. So oral antifungals, for babies and neonates, if the risk, after considering risk versus benefit, I think babies we don't give, but I think what the LRH practices is for children they are using fluconazole. Both itraconazole and terbinafine orally are not recommended for children. And for mothers, pregnancy and breastfeeding, now we see a lot of mothers with extensive tinea during pregnancy. So now we have started giving terbinafine orally. It is safe. Itraconazole is not safe. Terbinafine is safe, especially after the first trimester. So second and third trimesters we give. But breastfeeding, the only thing that can be given is fluconazole, but fluconazole's action against filamentous fungi is like minimal. Right? That's where we stand. So today I started a breastfeeding mother just after delivery on fluconazole. Right?
Less than 2 months, what should be given for scabies?
Sulfur.
Sulfur.
2% sulfur ointment.
So that is the end of our questions. So thank you very much, Madam Indira Kahawita, for joining us today and for that very informative and that eye-opening lecture and the speech. Thank you so much to our participants, and see you in 2 weeks' time.